Everyone, I'm Jolanda and I'm a doctor. I'm doing a medical education master's right now, so today I wanted to teach about a topic called microsurgery. I'm not sure what you know about it, but I want to give you a snapshot, a history, and kind of its useful applications and some interesting facts about microsurgery. So my first experience in microsurgery was when I was a fourth year medical student at Cambridge. I had a consultant that asked me whether I wanted to try my hand at microsurgery, and I hesitated for a millisecond and I jumped to the microscope. I was already strapped in for the operation, by the way, and when I'm looking at a microscope, I moved my hand a centimeter and I was really shocked at how much the instrument moves under the microscope. And I was really able to admire kind of the surgeon's dexterity and how meticulous he was and how impactful it was, because if you don't kind of do a good vascular anastomosis under the microscope, it could cause a lot of complications. So I was really impressed and I wanted to learn more about it. So a brief kind of background about microsurgery. What is microsurgery? Microsurgery is any surgery that is less than 2 millimeters. So it's really small, really minute, and really kind of meticulous surgery. Basically, a lot of the plastic surgery that people do is flap grafts or kind of flaps or grafts. The flap is when you move like a muscle from one part of the body to another. And I think I was really amazed at how much plastic surgery could kind of improve people's lives and function. When I read Ganges, Komatsu, and Tamai, they did thumb replantation, so they were able to kind of rejoin the thumb, and Kobat did a toe to hand transfer. And this is kind of really impressive for me when I first learned about it, because the hand is so important for your everyday life, and when you kind of lose function of your finger, you get quite upset and it can really affect your life significantly. So by kind of doing this transfer from your toe to your hand, it really kind of restores a lot of functionality to your life. So they did this kind of surgery, and then BUNCKE in 1966 did the first microvascular toe to thumb transfer in a rhesus monkey, and from then on the field of microsurgery kind of developed. And there were a lot of other kind of different flaps and grafts. So in 1982, Song did a radioform flap. And one approach when seeing a patient, you need to examine them. And by examining them, you first look at the defect site. So defect site, you look at the size, whether it's large enough, whether you can do a split thickness skin graft, full thickness skin graft, or you need a flap, the site, and then the composition of it. And then after that, you would consider the donor site. So you consider whether it's a good donor site, and it really depends on the patient. So, when you're doing kind of transfer, you need to see whether the patient is normally active. Because if the patient is active, then you probably wouldn't want to use the latissimus dorsi, which is kind of used for like swimming activities, if a patient is really into swimming and climbing. So there's a lot of discussion with the patient, and you do investigations like blood. So you do a full blood count, clotting, and use and ease. There's a lot of debate on what kind of suturing is better, whether it's interrupted versus continuous. I won't go into that today because there's still a lot of debate. There's also debate about end to side versus end to end anastomosis. I think hands down end to side is better because there's actually a higher failure rate of end to end anastomosis, and although it's more technically challenging, I think the outcomes are better. And after you're done with the operation, post-operatively, I think a lot of plastic surgeons or reconstructive surgeons are really kind of afraid of post-operative outcomes. So definitely you need to monitor it, because as the time increases, the salvage rate of rescuing the flap kind of drops drastically. So early detection will definitely improve your outcome. And clinically, you can do it by looking at the color. Is it warm? Is it well perfused? The turgor, the temperature, capillary refill, and the pinprick. And you can use simple adjuncts like Doppler ultrasound, pulse oximetry, having a feel of the surface temperature to get a view of it. And I'm from Singapore myself, so when I was having the lecture, I think there were quite a few subtleties that the lecturer gave about Singaporean plastic surgery versus plastic surgery here in the UK. And plastic surgery in Singapore, you don't give routine flexing. So in the hospitals here, I always prescribe 40 mg of Clexane if their renal function is fine, they're over 70 kg, or 20 mg of Clexane if there are any other complications. And it's so important, like people always drive home, that you need to have thromboprophylaxis. But in Singapore, the Han Chinese population have a really high risk of kind of bleeding. So the Clexane use is not really advocated for in Singapore. There's also no trem flap just because of the anatomical differences. And so, they've also noted that there's a lower smoker population in Singapore. So, there's still a lot of debate whether smoking affects the post-operative outcome. When you actually do the microsurgery itself, you use a jeweler's forceps and you need to be really delicate with the tissue. I think the top tips for preparing for microsurgery is really get the basics right. Like practice suturing on a banana, on a pork belly. And then for actual microsurgery, a lot of the surgeons that I've talked to have used chicken's feet, chicken heart. So these are quite low-cost items that you can use. Just cut them in between and try to join anastomosis with it. I've had quite a few reps give me their vascular anastomosis to try out, but sadly I haven't found any yet to be very kind of replicative of the real feeling, so I wouldn't recommend any right now.
To release that, you just push it in.
Just push, yeah. And to lock it.
So see what you like. But I suspect this needle is quite big, so actually will fit this better.
Alright. And then do I use these small forceps?
Yeah. So these are the really small forceps. These are the really small needle holders. And that's what you use when you start using your, when you start doing the real fine stuff.
Okay. Do you think I should just use these ones, or should I just try both? Yeah.
The other way around with the tips. Just like you did just now with the regular needle, and you're going to hold it in your hand.
Yeah. So it's a little bit too hot, a little bit too close forward. It's okay. As much of the arm as you can.
Now the other thing you're going to be used to is holding your hands apart. Now if you hold your hands apart, it can become quite shaky. Try and rest your hands on something. You must be ultimately very comfortable when you're doing this.
No,
The depth is like really
Well, it's because that's not stereoscopic. You see the small movements are really magnified on it, so try and keep your hands on the table. The sides of your hands on the table. If your hands are floating, you will tend to go up and down, left and right, and you get lost.
like the normal flashback.
Oh, right.
So it's permanently on and you can see better.
Okay, yeah.
Far side towards you. That's how the sort of process goes. I'm going to show you now on the heart, and actually we've chosen heart.
So what you can do is just insinuate underneath the skin using this motion. Go very superficial. The skin should set.
So much for listening. This is my first ever YouTube video. So if you have any questions or comments, please leave it in the comment section. Thank you.